Hello, and thank you for joining the Systems for Action RESPROG webinar. My name is Chris Lytle, and I'm Deputy Director of Systems for Action. Systems for Action, also known as S4A, is a national research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. We support studies across the country, testing tools and models to facilitate multi-sector collaboration across medical, social, and public health systems with a goal of improving population health and advancing health equity. Our RESPROG webinar series serves as a platform for S4A investigators to share findings at various stages of their studies and provide commentary on the potential impact of putting their findings into action. Today, we are joined by Dr. Glenn Mays, Department Chair of the Health Services Management and Policy Department at the Colorado School of Public Health and Director of Systems for Action National Program Office, and Dina Brossi, also of the Colorado School of Public Health. They'll discuss how multi-sector community networks are shaping COVID-19 pandemic trajectories and outcomes across the US. If you have questions for our investigators, please enter them in the Q&A box, and we will have time for questions at the end. And with that, I will pass the mic along to Dina Brossi.
Thank you, Chris. So I'll just go ahead and get started. A little bit of introduction into the COVID-19 pandemic. First documented case was in the US was in January 20th, 2020. And since then, we've had over 5 million documented cases and over 170 reported deaths in the US. And the United States has among the highest reported death rate per 100,000 people among developed nations. I don't know if I can go to the next slide. There we go. And these death rates are not constant across the US. We do know that there are disparities across different populations in the US. Black and Hispanic Americans are more likely to die from COVID-19 than their white counterparts. And as you can see by this map, there are disparities geographically across the US, with some of those southern and northeastern states having higher COVID-19 death rates per 100,000 people than maybe some of the Midwest and Western states. And there has also been a variation in policies around COVID-19 safe practices in states and localities that may contribute to some of this geographical variation. And so just an introduction into one of the things that Systems for Action does. We conduct a nationally representative survey to US communities in order to get information on the implementation of public health activities and the network of organizations that participate in those public health activities. This survey is completed by a local health official in each community, and we use this survey to kind of construct some information about the public health system and the capabilities within each community and the network strength for each of those activities. And then using that analysis data, which is pretty rich in public health system information, with COVID-19, we are trying to look at, do communities with stronger public health systems experience fewer COVID-19 deaths? And what are some of the attributes of the public health systems that correlate to the COVID-19 mortality? Specifically, we'll be looking at the public health activity implementation and then the network density for those organizations that participate. So our sample for this analysis is the 2018 wave of analysis, which constitutes a nationally representative sample of metropolitan communities, around 296, a nationally stratified sample of rural communities, around 254, and then communities from 4 states, Ohio, Kentucky, Washington, and Oregon, which constitutes around 173%. The response rate for the 2018 wave of analysis was 71%. And I'll get into this later on in the slides, but we also do reduced models, and the reduced sample models will exclude the volunteered communities from those 4 states. The main measure that we are looking at is the system composite score that's created from the analysis data set. And the score is calculated using a combination of public health activity scope of the community and then the organization partnerships or network density variables. And this is done using a cluster analysis. Some of the organizations that might partner with a public health activity that's implemented in the community are law enforcement, hospitals, some public health agencies. And some of the activities that we're looking at are, say, investigation of disease outbreak or education around certain public health issues in the community. And this variable results in three natural categories: comprehensive, conventional, and limited public health systems. And a comprehensive public health system is a community that implements the most public health activities and has the largest network of organizations participating in those activities, whereas a limited would have the least number of health activities implemented and the smallest network of organizations participating. And then the data we'll be using is the analysis. The COVID-19 death rates per county was collected from Johns Hopkins Center for System Science and Engineering. The area health resource file allowed us to get variables on like nursing home population at the county level. We also have data from Atlantic's COVID tracking project on statewide COVID testing rates per 100,000 people. The CDC's compressed mortality file was used to get deaths from diseases that are at high risk for COVID-19 deaths, such as HIV or COPD. And then the New York Times 2016 presidential election data. For our analysis, because there was a higher than expected number of counties in each one of these system composite counties with zero COVID-19 deaths, we had to employ a two-part model. And the first part model is a logistic regression that would model the probability of a county having zero COVID-19 deaths versus more than zero COVID-19 deaths. And then the second part would just look among counties with at least one COVID-19 death, what is the distribution of those COVID-19 deaths? And we use a log transform in order to get that distribution to be normal. So here are some of the county characteristics across the public health system composite scores. Most of them are not statistically significantly different across each of these categories, except for if you look at rurality, limited public health system counties are more likely to be rural than comprehensive or conventional. And then there is also higher numbers of COVID-19 risk deaths per 100,000 people in limited versus conventional and comprehensive public health system counties. They are more likely to have a Republican state governor, and they are also have a higher nursing home population per 100,000 people. And while we do control for all of these variables in the analysis, it is important to keep these ones that I've noticed in mind, because these variables might also, kind of signal why there might be more COVID-19 deaths in a county that's not related to public health system capacity. And just to give you a little bit more information about the public health system categories, these are unadjusted, so these don't control for any of the characteristics that you saw in the previous table, but it looks like on average, the conventional public health system counties have higher death rates than comprehensive and limited, and that's just unadjusted, not looking at anything. They all have kind of the same, peak trajectory with a little bit of a spike happening at the end of June for conventional. So then looking at the results of the two-part model, these are estimates for the logistic regression, the first part, and the GLM part. Normally, in the next slide, I will show you the estimates that combine these two. So these are just the estimates for each one of the models. And then the next step is to look at the combined estimate for the entire sample. But we can see that the system composite rating was not significantly related in the logistic regression. So the probability of having no COVID-19 death rates was not different across the system composite rating score, but it was significantly different in the GLM. So among counties with at least one COVID-19 death rate, that distribution of COVID-19 deaths per 100,000 people was significant across this categorical variable. And so then looking at the combined full and then reduced models, and I'll get into a little bit more about what the reduced models, what the definition of them are. If we look at conventional public health system counties, there are 13.1 more deaths, COVID-19 deaths per 100,000 people in conventional versus comprehensive public health system counties, and 9.12 more COVID-19 deaths per 100,000 in limited counties versus comprehensive. And like I said prior, the reduced sample is just including the metropolitan and rural communities, and the reduced covariant model, if I actually go back to the characteristics, we removed some of these variables because we were unsure of, what they were actually signaling. Specifically, the Republican county lives in or has a Republican state governor. County voted for Trump in 2016, and state COVID-19 tests per 100,000. We were unsure about how those would affect the model. We were trying to get at maybe individual level behavior with some of those variables, but we excluded them just in case that they were overly burdening the model. And no matter which sample or covariate model specification we chose, the system composite rating was significantly predictive of COVID-19 death rates. And so then taking those estimates, those adjusted estimates that we found, and applying it to a map, if we were to change all of the counties that were limited or conventional public health systems to comprehensive, this would be the reduction in COVID-19 death rates per 100,000 that we would see, where some states have higher conventional and limited public health system counties, and where there could be more room for improvement on COVID-19 death rates. So there is a negative correlation between COVID-19 death rates and local public health system capabilities. This kind of goes along with the anecdotal reports suggesting that public health departments lacked resources and staffing necessary to address the pandemic. And then maybe those local health departments with more resources and more partners in those activities that they were implementing are able to direct some of their efforts towards the COVID-19 response. Maybe they could direct anything that they were doing in infectious disease outbreaks towards that, or take some of the educational work that they were doing and translate it into more testing or more contact tracing. Some limitations of this study: the local public health officials are the respondents, but they may not have full knowledge of all of the public health system activities or networking that's happening in the community. And this is especially true if it's occurring outside of the public health department purview. So if a hospital is partnering with a law enforcement, or it's outside the public health department, but it's still being conducted, it might not be captured using the analysis. For the 2018 wave, like I stated, only 71% of the analysis sample responded. And if there was a systematic reason for the other 29% not responding, maybe they, didn't have as many activities that they were conducting, or they didn't have as many partners, then that would influence that, system composite score with COVID-19 death rate relationship. The COVID-19 deaths that we collected from Johns Hopkins were underreported in the beginning months, January through March. This is mostly because they probably would have been coded as flu or maybe something else in those beginning months. And if this was systematic by the state or county that was reporting them, that could present problems. Maybe certain states were, not tracking as closely as others. Maybe New York was tracking more closely than Colorado. And if there was a differential in how they were keeping track of those COVID-19 deaths that could have some problems, especially if that's related to the public health system capabilities. And this analysis is cross-sectional. The data that we collected was for COVID-19 death rates was through the end of June up till July 1st. And we just took all of the deaths at that point and then compared it to the system composite score that we collected in 2018. And so if there was any variables that we did not include in as controls, there still could be some unobserved confounding that is not captured using just a cross-sectional regression. So then looking forward, this analysis was only the first wave of COVID-19, and there have been, rising cases, rising deaths, especially through July and August. And so we definitely need to continue to do this research to make sure that this relationship still holds, even with the new spike in cases and the new spike in deaths in areas that hadn't seen cases and deaths before. So, some of those southern states that we have been seeing those increased deaths. And we have also been thinking of, using the analysis to maybe interview some of those public health respondents about what their response has been on the ground, what it looks like, what some barriers to addressing, the COVID-19 rising cases or deaths has been like, and how we can maybe overlap that with some of the results that we're seeing in this analysis with the system composite score and COVID-19 deaths by county. And that's all.
Thank you so much, Dina, for sharing with us your findings that you've been doing on as for intramural work. Really excited to see the next steps of your analysis. Again, I want to let folks know that we'll use the latter half of our time to field any questions for Dina. If you have any questions, feel free to enter them into the Q&A box at the bottom of your screen, and we'll give you a few minutes to do so if you would like. Okay. So we have a question from Ali JP. Dina, they'd like to know what's the definition of all the different systems, conventional, etc.
Yeah, thanks, Ali. So the three different system classifications that we had, comprehensive, conventional, and limited, define the essentially the number of public health activities that they implement in the community and the number of organizations that they partner with, the density and the width of those networks that they partner with. And it's a combination of those two measures combined into one to develop a system composite score of activity implementation and then network for public health.
Awesome. And Dina, I'm curious, given the amount of stress that the COVID-19 responses is going to put onto local, public health departments, do you anticipate any additional hurdles to next steps in your research?
Oh, absolutely. As far as, getting out another survey to interview, public health officials on what's happening, I'm sure their time is already binded for everything that they're dealing with. Collecting this data might be additional burden on them. And I mean, they've already been struggling for the past several decades for funding and staffing, and there's no indication that they're going to be receiving it now when they need it more than ever. So lots of barriers, lots of potential problems.
And could you talk a little more about the prevention implications of the survey work?
Yeah, so one of the things that I feel like a lot of experts have been saying, one of the reasons why the United States has had, the highest death rates among developed nations is because of our lack of testing, our lack of contact tracing, our lack of doing, just basic public health activities that are supposed to stopgap the spread of this COVID-19 virus. And, just understanding that there are a lot of states with these limited and conventional public health system counties kind of lets us realize and shines a light on the fact that we do need to put more efforts and more resources into this. And I think that's why it is important to then go forward and, get more, maybe like detailed interviews from some of these communities to see like, okay, well, we can see that their efforts are lacking for whatever it is, funding, resources, staffing, et cetera. Where can we best direct additional funding that we give you, or additional efforts, or how do we, best make use of those resources that we will give you or that we want to give you? So there's a lot of things in prevention that we need to start looking at, and we have a long way to go.
Awesome, thanks. And we have a question from CV Memero. And they would like to know if you could expand on the Republican governor finding.
Yeah, absolutely. I think she's got the screen. I wonder if I can go back to that slide. I can talk about it without the table, but I thought that was really interesting too. And actually so both the variables of county is in a state with a Republican governor and voted for Trump in 2016 were in the opposite direction of what I thought they would go. So if you were in a state with a Republican governor, or if you voted for Trump in 2016, you had less COVID-19 deaths per 100,000 people in the GLM. And that's why, again, we excluded them in some of the additional iterations of the model, because it did not go in the way we expected. I'm assuming that it has to do with, some of the fact that Republican counties are less likely to be urban, have a smaller population density, some other factors that have been, trending more towards Democratic counties and states with Democratic governors having more COVID-19 deaths. But I was trying to, for those variables, I was trying to get at, what would individual level behavior be? So I was thinking in a county that voted for Trump in 2016, they might be less likely to abide by COVID-19 safe practices, or would have less policies at the county or state level around, wearing a mask, or have the ability to go testing, some of those things. And I think there was just too much, there was just too much noise with those variables. And I think it was capturing some other things that I wasn't intending it to, but it was still very interesting. And you still see in those models where those variables are included, we still see an increase in deaths compared to comprehensive public health system counties versus conventional and limited. So it's still an interesting finding, even with those variables included.
Okay, thank you. And Jean McGuire wants to know if you could talk a little bit more about public health capacity. For example, how do you disaggregate the circumstances of those local public health entities that also have either large hospital systems, plans, or other healthcare and related service mechanisms within or closely related?
Yeah, that's a really good question. And so I didn't specifically look at, that might be something that we could do in the future, is specifically look at, okay, which organizations are involved in these public health activities? Is it like a big hospital system or a big hospital network? Is it, law enforcement, or is it just like the public health and social service ones? So as far as this system composite score, it doesn't separate out whether or not, the county had a big hospital system and whether that was one of the reasons why they had more or less burden for COVID-19 deaths. And would be a very interesting thing to look at is, does this relationship change when you start getting more into the details about what types of networks and what types of organizations are involved in some of these activities? Really good question.
Thank you. And we have a good follow-up question to that. The COVID simply didn't hit every state equally during the study period. For example, Harris County in Houston looks good compared to New York in the spring, simply because the virus didn't get there yet. Mm-hmm. How was this taken into account? And this question's from Michael Stodo.
Yeah, good question. As far as, you were kind of addressing what I did in the discussion part, which is I was just looking at the first wave. And of course, as we continue, going through this pandemic and more places get exposed and more cases pile up and deaths, we will be able to get a better sense of, the trend and the tracking of it. But I did not, this was just purely a cross-sectional look at, what counties had been exposed. Usually it's related to a lot of the factors that I controlled for. So population density was a huge factor, and population, percent of the population that was rural, all of those variables that I controlled for would, kind of feed into that relationship. And so the next part would be to, further look at, okay, well, when it does hit these counties, what does that look like? And we could have potentially tracked this change over time. So instead of doing just a two-part model at one point in time, looking at changes over time from, January to June, using like a Poisson, so a count model for each day. The problem that I found with that is that Johns Hopkins, to the best of their ability, they're as reliable as they can be, but sometimes the counts fluctuate in a way that doesn't make sense. So their cumulative cases would be 70 one day and then 65 the next, where it's like, how can you have less deaths than you did before? So there were some data problems that prevented us from doing anything over time and tracking that. But maybe, as the, pandemic progresses and we get more data and you have better systems for collecting data on this, maybe somebody could track the change over time and kind of get at, that spread, that infectious disease spread model. But yeah, I didn't, aside through the covariates that I included in the model, I didn't directly measure how, some cities got exposed first as opposed to others, and just more time and data as far as my model specification is needed.
Thank you. And to build off of that, Beth Bresnick would like to know, oh, sorry about that. Would like to know, what about, since COVID deaths seem more healthcare outcome measure, what about things that the public health system might be more directly involved in, such as testing, mask requirements, indoor activity restrictions, and so forth?
Right. Ideally, I would have wanted to use COVID-19 cases, because that kind of, gets more at, is the public health department testing? Is the public health department contact tracing? Things that would be more specifically preventable, and specifically usually the focus of the public health department. I mean, in some areas that has kind of been placed on the hospital systems, but usually that's the role of the public health department. But there have been some data validity issues with cases. And so in order to, kind of skirt around those, I use COVID death. But if, again, like I was saying for the other question, if there's a way that we can look at the relationship between COVID cases in this second wave, where data collection might be a little bit more robust and might be more accurate, that would definitely get towards more of what Beth is saying, where but it also does seem, it is a step beyond, testing and then death. But yeah, we would want to look at COVID cases in relationship to this public health system response variable, and then maybe map it onto death. But I wasn't confident in the COVID testing data to do that.
Okay, and Kristen would like to know, were any proxy variables for institutional racism in healthcare included in your GLM?
So I included a percent of the population that is non-white. I also included, there was some studies that suggested that household size might be able to get at, proportion of population that, if there's like more people in a household, maybe that could get more at poverty, that could get more at low income, can get at, some of those areas that might be impacted. Institutional racism, I don't think so I had the variables on percent of the population that's non-white, but I don't think I had anything as far as like, bias in hospital systems or any variables that were related that way. My political variables could have maybe gotten towards that in a sense, because Black Americans are more likely to be Democratic, but that's also a city urban thing. So I don't think I was able to get any variables as far as institutional racism in healthcare. I wonder what variables could get at that, could proxy that. That would be really interesting. I'm not sure how I would be able to get at that.
All right, great question, great response. We have a few other questions. Dina, are you good for a couple more?
Yeah, these are great questions.
All right, so in the survey itself, Lena Toma would like to know whether you looked at public health systems belonging to Native American communities or tribal nations.
Yeah, that's a really good question. Unfortunately, for the 2018 one, I think that was actually the first year that we asked questions, any questions related to tribal communities or Native American communities. Unfortunately, like I said to another question, this measure doesn't get at, what sorts of organizations they're partnering with. And I think for the 2018 one, I would be able to, if I wanted to, look at what organizations the communities were partnering with in order to implement the public health activities. So that could be done, but I did not specifically look at that. And the measures for race, ethnicity that I used were just percent not white. So I wasn't able to specifically get at Native Americans, but that one is really interesting since it's kind of disjointed from, regular state, local, federal public health systems.
Awesome. And this next question is more so a statement that you can riff on. Julia says that because the health system classifications include a lot of elements, it will be interesting to see whether specific elements, not just the number of elements, characterize jurisdictions with lower death rates.
Right. Yeah, and I did play around with a little bit of that. So the activity scope variable, we actually have a variable for just that, the activity scope, not combined with the network density partnership with other organizations. And with that one, because there were, there's about 20 different public health activities that we survey on, and then each one of those gets a, we implemented it or we participated in this community or we didn't. We have kind of a continuous score for that one. And I'll be honest, I don't remember if it was significant or not, but it was just a little bit more difficult to convey. This one seemed to be a little bit easier to, articulate and understand as far as like, okay, these are some of the communities with the best public health system capabilities versus the, the lowest public health system capabilities. And comparing those two seemed to be a little bit easier. But we did look at, whether or not a local health department was accredited, federally accredited. That was significantly predictive of COVID-19 deaths. And we did have a few sensitivity analyses where we looked at other outcomes and the relationship was significant. So if I had to guess, I would assume that that relationship would still hold, even with the individual components of that variable.
Thank you so much, Dina, for those responses. If folks would like to learn more about our national survey and our findings, please find more on our website, systemsforaction.org. And of course, if additional questions come up for you that you'd like to discuss with Dina or with Glenn Mays, feel free to reach out to us directly. We'll provide you with contact information following this presentation. And with that, again, I really want to thank Dana Brasi for discussing her work with us. If you would like to receive a certificate of completion for today's ResProg webinar, there'll be a survey at the end of the session, and we'll be able to email that to you. And if you're interested in hearing more about our research in progress, we'll be back again, same time, same place, September 2nd. Dr. Daniel O'Connell and Christy Fisher at the University of Delaware will talk about the testing the impact of a referral program to link probationers to primary care. And on September 16th, we'll hear from Dr. George Nafal and Emily Naser at Texas A&M about addressing the health and social needs of justice-involved young adults. And as always, we want to thank the Robert Wood Johnson Foundation and to thank you all for joining us to hear about the research that we're doing here at Systems for Action. Thank you, and again, we'll see you in September.